Welcome to the Deep Dive, where we take a stack of dense academic material, distill it right down to its most valuable insights, and deliver the knowledge you need to be well-informed and fast.
Exactly. And today we're tackling a really critical topic for anyone involved in high-load activities.
We're talking about chronically injured tendons, and specifically that one rehabilitation technique everyone talks about, eccentric training.
Yeah, tendinopathy can be career limiting, and for years we've relied so heavily on eccentric training, or ECC, to fix it. Our mission today is to, move past the hype.
Right, and really analyze the global evidence.
To see if ECC truly is the gold standard, and maybe more importantly, if the way we're all prescribing it is actually optimizing long-term tendon health.
And we are grounding our entire discussion today in a truly exhaustive piece of research. It's called Eccentric Training for Tendinopathies in Athletes, a scoping review and evidence gap map.
It's a big one. Published in 2026 in the Journal of Sports Science and Medicine. The lead author is Robert Trybulski, along with Gracjan, Olaniszyn, and their colleagues.
So they analyzed 31 high-quality studies.
And they focused only on athletic populations, which is key. The big overarching finding is something you need to grasp right away. While ECC consistently helps with pain and function.
Which is great.
It is, but the sheer variety in how it's prescribed, the dose, the frequency, the load, it's just massive. There's a real lack of standardization, which makes defining the best protocol a huge ongoing challenge.
Okay, so let's start at the beginning then. The root cause. We hear people throw around the term tendinitis, but the sources are clear that tendinopathy is a totally different beast.
It's so important to make that distinction. Tendinopathy is a chronic tendon disorder. That adatitis suffix implies acute inflammation.
Right, like a fresh injury.
Exactly, and that's largely absent here. What we're actually seeing are degenerative changes. We're talking about disorganized collagen fibers, an increase in what's called ground substance.
Which is what, exactly?
It's basically the non-collagenous material, the gunk that weakens the tendon's structure. And on top of that, you often get neovascularization.
Okay, let's pause on that one. Neovascularization. It sounds like something good, like new blood vessels are growing to heal it.
You'd think so, wouldn't you? But in this case, it's part of the problem. These new blood vessels often grow alongside new nerves that carry pain signals, and they just interfere with the tendon's natural organized structure.
So they're part of the pathology.
They are. And this whole degenerative state, it accounts for a huge drain on performance in sports. We're talking 30 to 50% of all overuse injuries.
The numbers are staggering. I mean, patellar tendinopathy jumper's knee can affect up to 40% of volleyball players.
And Achilles tendinopathy, you see that in 8 to 15% of runners. It's a massive issue.
So for decades, the question has been, how do we reverse this degeneration? How do we reorganize that tissue?
And for a long time, the answer that kept coming back was eccentric training.
So why ECC? What is it about that lengthening phase of a muscle contraction that makes it such a powerful therapeutic tool? What's the secret sauce?
Well, the core concept is that the muscle tendon unit is performing a controlled lengthening while under a really high load. Think about when you lower a heavy weight slowly.
That negative phase.
That negative or eccentric phase. It generates significantly higher tension in the tendon tissue compared to the concentric phase where the muscle is shortening.
So you're creating maximum tension, but on purpose.
Precisely. And the physiological aha moment here is that this high tension is achieved with a relatively lower metabolic cost to the muscle.
So it's efficient.
Very efficient. It's an efficient way to stress the tendon. And that powerful, controlled mechanical stimulus is the key to driving mechanotransduction.
Mechanotransduction. Okay, that's a word that needs a proper breakdown.
It's the whole magic of the process. It's how the cells within the tenocytes convert that physical stress, that heavy eccentric load, into biochemical signals.
And those signals do what?
Those signals basically tell the tenocytes to ramp up new collagen synthesis and start remodeling the damaged, disorganized tissue. You are literally using heavy load to tell the body to build back stronger.
That sets the stage perfectly. So,
Yeah.
Looking at the evidence map from the review, where has all this research been focused, anatomically speaking?
It's heavily focused on the two big problem areas for athletes, the knee and the ankle, so patellar tendinopathy.
Jumper's knee.
Right, common in volleyball, basketball.
Yeah.
And then mid-portion Achilles tendinopathy, which you see everywhere. Runners, soccer players, you name it.
Let's dig into the patellar tendon protocols first. The review points to the single-leg decline squat as sort of the centerpiece of therapy. What's so special about doing squats on a 25-degree board?
The angle is everything. When you do that squat on a 25-degree decline, it shifts the load. It increases the passive stretch and forces maximum tension right onto the proximal part of the patellar tendon.
So it targets the exact spot where the problem usually is.
Exactly where the pathology often resides. It's a highly targeted movement.
And the results they cited, I mean, they were pretty eye-opening, weren't they?
They were stark. There was one famous study that compared an ECC group doing the decline squat versus a group doing only concentric work.
Yeah.
In the ECC group, 9 out of 10 athletes returned to sport. In the concentric-only group, 0. 0 out of 9 returned to sport. They all ended up needing surgery or injections.
Wow. That's a massive difference.
It really underlines the unique benefit of that eccentric load. And what's more, that specific decline squat protocol delivered more durable benefits even a full year later compared to older eccentric protocols.
Okay, so let's move down to the Achilles tendon. This is where we see the famous and very rigorous Alfredson heel drop program.
Ah, yes, the Alfredson program. It's all about high volume, high frequency. You're doing eccentric calf raises with both a straight knee and a bent knee.
And how often?
3 sets of 15 reps, twice a day, 7 days a week.
That is a serious commitment.
It's a huge commitment, but the sources show it's highly effective for symptoms. The VISA-A scores, which is how we assess Achilles function, improved dramatically by 30 to 40 points over 12 weeks.
And return to sport?
One of the early trials reported a 100% return to running by that 12-week mark.
Incredible. But the review introduces a really interesting alternative. Heavy slow resistance, or HSR. How does that stack up against the daily grind of the Alfredson model?
Well, they're different beasts, really. HSR is lower frequency, usually 3 sessions a week, not 14, but the load is much, much heavier.
So you're lifting heavy.
You're lifting heavy. You progress from higher reps down to a heavy 6-repetition maximum, or 6RM. It's much more like traditional strength training.
So if the Alfredson protocol gets such great results, why is the evidence now pointing towards HSR as being comparable, or maybe even better?
This is such a crucial point for anyone listening. HSR is often just as good, but sometimes structurally superior, especially for long-term outcomes and patient adherence.
People are more likely to actually do it.
Who wouldn't prefer 3 sessions a week over 14? But physiologically, the high absolute load of HSR is just superior at driving that necessary tight collagen synthesis. It seems to be better at rebuilding the actual structure, not just making it feel better.
Treating the pathology, not just the symptom, that's a key takeaway. Let's shift gears to maybe the most counterintuitive part of all this, the role of pain.
Right. This is where a lot of traditional rehab thinking gets turned on its head. Successful eccentric training doesn't avoid pain. It uses the pain signal to determine the right therapeutic load.
Wait a minute, so you're asking an athlete with a chronic injury to train into pain. That sounds risky. How do we know they won't just make it worse?
It's a fair question and a critical one. The assurance comes from controlling the load and staying within very specific thresholds. The protocols consistently allowed exercise into a state of, let's say, moderate discomfort.
Okay, so what are the numbers? What's that sweet spot on the pain scale?
They found that progression was generally allowed when pain was sitting around a 4 or 5 out of 10 on a visual analog scale, or a VAS.
A 4 or 5. So you definitely feel it.
You feel it. But if the pain spiked above a 6 or 7, the load had to be decreased immediately. That 4 to 5 window is the essential signal. It means you're getting enough mechanical stress without going into a harmful zone.
So that controlled, tolerable pain is actually a good sign. It means you're stimulating that remodeling process.
Precisely, and this is totally different from, say, some isometric training protocols, where the goal is to keep pain below a 3 out of 10. For high-load ECC and HSR, you need that mechanical input to drive adaptation.
That is a critical insight for anyone designing a rehab plan. But now, let's pivot to the problems. Despite all this success, the authors found some serious limitations in the evidence. What was the biggest disconnect they found?
The biggest scientific dilemma is the gap between how an athlete feels and their objective physical capacity. While pain and function get better consistently, the evidence is all over the place on 2 metrics that are critical for athletes.
Okay, what are they?
First is performance. Things like vertical jump height, max strength, change of direction speed.
Right.
They were all inconsistent across the studies, even when the athlete felt way better.
I see. And the second?
The second is tendon structure. Some protocols did a great job reducing that neovascularity and improving collagen organization, but others provided fantastic symptomatic relief without any real observable structural remodeling.
Oof. That's a clinician's worst nightmare, isn't it? If the tissue isn't actually healing, what happens 6 months down the road when they go back to full competition?
It creates a huge risk of recurrence. If you only treat the pain signal without rebuilding the tendon's capacity, it's still a compromised structure. This really highlights why that shift toward high-load protocols like HSR is so important. They seem better at bridging that gap.
How about other gaps? Let's talk safety. Was there a high rate of adverse events?
The safety profile is generally really strong, which is reassuring. Across all 31 studies, adverse events were minimal, mostly just some temporary muscle soreness. But the reporting itself is inconsistent, which is a gap. And we do have to mention the one single serious adverse event reported. One Achilles tendon rupture occurred in an ECC group. It's a reminder that load management is absolutely paramount.
In the scientific rigor of the studies themselves, what were the big challenges there?
Two main issues. First, and this is a big one, is blinding. You just can't do it.
Right. An athlete knows if they're doing a squat or a heavy leg press.
Exactly. So nearly all the trials had a high risk of bias because participant expectations can influence self-reported pain and function. It's just the reality of exercise research.
And the second issue?
The second is what they call methodological heterogeneity, just massive confounding variability in the prescriptions. You have the Alfredson model at twice a day, 7 days a week, and other successful protocols that are just 3 times a week.
So it's hard to compare apples to apples.
It's almost impossible. And that variance really limits our ability to pool the data and define one single optimal dose for every tendinopathy.
Finally, the evidence map showed that once you step outside the world of Achilles and patellar tendons, the data just falls off a cliff.
It's dangerously narrow. The review highlighted a massive evidence gap for other important sites. The biggest one, by far, is proximal hamstring tendinopathy, or PHT.
Which is a huge problem for sprinters and dancers.
A debilitating injury, yes. And yet, the review found only one single controlled trial that met their criteria. We simply can't draw strong evidence-based conclusions for managing PHT with eccentric training yet.
So bringing this all together, this deep dive gives us a really crucial update. ECC is still a cornerstone, but it seems the science is pushing us toward higher loads.
Yeah.
What's the final provocative thought you want to leave our listeners with?
I think the key takeaway is this. Traditional eccentric training, like the Alfredson protocol, is safe, and it's highly effective for immediate pain relief and getting an athlete back to functioning. No doubt about it.
But there's a big but coming.
There is. If your focus is truly on restoring long-term tendon capacity, on structural resilience, on preventing this thing from coming back, you should be looking very, very hard at the heavy slow resistance protocols.
Because they rebuild the structure better.
The evidence suggests they do. While the daily high-rep program gets the athlete feeling better, the heavier, less frequent HSR approach seems to drive the superior adaptations needed to rebuild the tendon into a robust, truly resilient structure.
That distinction, feeling better versus being better, is such a critical nuance. We really encourage you to seek out the full publication by Trybulski and colleagues to explore all the details we discussed today.
Yeah, understanding these gaps and the subtle differences in dosing is really the key to moving from just general therapy to truly personalized, evidence-based athletic rehab.
You've been listening to The Deep Dive. If you want more targeted analysis just like this delivered straight to your feed, make sure you follow the channel and turn on those notifications. We'll be back soon to tackle another essential topic.